So this is a presentation from Eleri, Sargent and Sarah Davies from Hywel Dda Speech and Language Therapy Service on how we have implemented a remote telehealth service for clients with acquired dysphagia.
Okay, so what we did, as a service, we had been investigating the safety and efficacy of utilising telehealth to deliver remote swallow assessments. And then when the COVID-19 pandemic began, we were recommended to follow a virtual first approach to avoid unnecessary face-to-face contact with our service users. We were also faced with additional challenges with several staff members shielding, in addition to staff having to work remotely. All these factors prioritised the need to establish a telehealth service with a view to enabling the assessment and management of a service user's swallowing difficulties remotely, while minimising the impact of delayed swallow assessments on service users and preventing an accumulation on service demand. So why we did it? With many of our care facilities being inaccessible or significantly restricting access to external users, our outpatient clinics being suspended, and service users in the wider community shielding, we needed to find a way to continue to safely manage our service users' ongoing needs relating to their swallowing difficulties. We also needed to continue to address concerns raised by new referrals to our service, which had continued. It was anticipated that this service delivery model would improve access to our service users, reduce waiting times, and offer a comparative alternative to face-to-face assessments, thus benefiting the service users' health and well-being, while avoiding the potential adverse risks and negative health consequences to the service user should delayed access continue. It was also anticipated that it would increase staff satisfaction and add to their skill set from both a speech therapy staff perspective and for those staff members working with service users in care facilities and their own homes.
So now we look at how we did it. So faced with the challenges of outpatient clinics closing and care homes effectively becoming locked to any external visitors, we got together and brainstormed and looked at the evidence base around the use of virtual telehealth systems. There's a lot of evidence-based research out there that telehealth can really be beneficial for services and for the patient users. And we looked at some of the practices that were already going on. We found the Queensland Telepractice Dysphagia Service online training, which we completed, which talked us thoroughly through how to complete dysphagia assessments remotely, looking at the roles of the SLT and of your SLTA or an additional healthcare practitioner at the remote end of the service. We were also bombarded with information regards different platforms that we were enabled to use, such as Attend Anywhere and Microsoft Teams, and we completed the relevant training in those systems to see whether they would be fit for purpose. Once we decided that we wanted to trial the use of telehealth for dysphagia assessments, we looked at developing some guidance on how to complete a dysphagia assessment remotely, bearing in mind that we wouldn't physically be there to be able to have hands-on assessment with our patients. As part of this, we looked at devising a dysphagia risk assessment. So our usual numbers of referrals were still entering the department. We'd complete our usual triage processes, and anyone who was a high priority level 1 patient would be offered a face-to-face assessment. For those who were deemed lower priority, we would rank them using the dysphagia risk assessment to determine whether a remote assessment would be appropriate. This would look at their social situation, the difficulties that they described, their past medical history, and the reported consequences of their current swallowing difficulties, to name a few. We then looked at devising some standard admin processes. These included some patient information and consent forms around performing an assessment, the technology that was needed by our service users, and the processes which we would follow. And this included looking at safeguarding if there were any adverse incidences. What we then did was conduct some practice clinics with colleagues to look at the views that we needed for a remote assessment, the quality of the images and the sound, and looked in detail at our dysphagia assessment protocol and what elements we could achieve effectively and safely. We then looked at implementing a PDSA cycle, and we've looked at phases 1 and 2 to date. And this is looking at phase 1 was with care home residents who were already on modified diet and fluids. So these were service users that we had contacted potentially several months ago when their referral initially came in, and we'd given some telephone advice. We looked at reviewing the need for ongoing SLT input and looking at offering virtual assessments to determine whether our recommendations had been effective and whether any changes were needed. We've just embarked on the second phase of our cycle, which is looking at, again, care home referrals, but new referrals. So at the point following triage, if they haven't been identified as a priority 1, we look at offering a virtual first approach for their assessment, and we complete the risk assessment. Phases 3 and 4 will be looking at patients in their own homes on modified diet and fluids already, and then new referrals for patients in their own home. But we anticipate that there will be a higher level of safeguarding around these, because potentially, you know, they will be perhaps with their partners who may have communication, language difficulties, social issues, where it won't be as safe for us to conduct those assessments. So far, the outcomes of our progress of our programme have been very positive. Luckily, we haven't had any adverse incidences yet to report of. The patient-reported outcomes have been limited, and that's because of the nature of the client group that we've been using. There have been a high number of care home residents with cognitive difficulties who've been unable to give us feedback on their experiences. We have, although, spoken to staff at the care homes, and the feedback has been varied. Initially, we've had a lot of restriction to wanting to do virtual assessments, particularly for the phase 1 patients, because the perceived outcome of our intervention wasn't met by the staff at the care home. They felt that they were already managing the patient's difficulties with the recommendations that we'd given, and they were asking as to what benefit further assessment would be, coupled with the challenges of completing a virtual assessment. The therapy outcome measures, we've looked at using our TOMS and our dysphagia outcome measures, and we've seen that for a percentage of our patients, there have certainly been an increase in modified diet, textures and fluids that we've been able to make recommendations of changes. So the degree of their difficulty was perhaps overestimated during a telephone review, but we were also able to have a holistic view of their difficulties and look at suggesting some alternative adaptations alongside any modifications to their diet and fluid. In order to ensure safety, at the moment, our PDSA cycle has only used 2 Band 7 qualified, or specialist, I should say, dysphagia trained therapists, and that is to ensure safeguarding around this process. So it's been myself and Sarah to date who have been completing the virtual assessments, but we've thoroughly enjoyed it so far and really seen the benefits there have been over and above just doing telephone consultations. Moving forward, we've definitely learned some lessons already. The compliance from care home staff is really imperative to a successful clinical virtual consultation. Having the staff who are willing to work with us and to work through any technical teething problems that we have has been really important. It has raised some questions around the safety of performing dysphagia assessments within care home establishments, particularly around the RCSLT guidance with regards to swallowing assessments being AGPs and what level of protective equipment the care homes have available. But definitely from our early studies, we will be looking at offering virtual assessments of swallowing as a first line offer of service delivery as we move forward with the new referrals that we receive. And we'd be happy to answer any questions over email or provide any specific feedback if anyone else is interested in learning more. And we do hope to publish some more of our findings as we collect some more data.